Welcome to our video review of 4 papers published in the Journal of Vascular Surgery in August. Each of these 4 papers is available for review and downloading for free during the month of August. The first paper is the JVS Editor's Choice by Schemmerhorn and co-authors and is entitled The Impact of Endovascular Repair on Management and Outcome of Ruptured Thoracic Aortic Aneurysms. The authors studied the National Inpatient Safety Sample and found that 12,399 patients underwent repair of a ruptured thoracic aneurysm in the most recent years of 2011 to 2012. They found that endovascular aortic repair, or TEVAR, was increasingly becoming the primary treatment for ruptured thoracic aneurysm at most institutions, particularly in the elderly, and that 43% of ruptured thoracoabdominal aneurysms were repaired with TEVAR, with a mortality of 22%. In an adjusted analysis, TEVAR had a 2-fold lower mortality than open repair. The proportion of elderly patients who had no repair has also declined significantly. The authors concluded that the introduction of endovascular treatment appears to have broadened the eligibility of patients for surgical treatment, particularly among the elderly, and that the mortality after ruptured thoracoabdominal aneurysm admission has declined since the introduction of TEVAR, which is the result of improved operative mortality, as well as the increased proportion of patients undergoing repair. The next paper, by Titus and co-authors from Abbott Northwestern Hospital in Minneapolis, was entitled A Prospective Randomized Comparison of Contralateral snair versus retrograde gait cannulation in endovascular aneurysm repair. It was a prospective randomized trial comparing retrograde with antegrade gait cannulation times and success. The authors found that gait cannulation was successful using both methods, with no statistical difference between the two in median time, but that retrograde cannulation was found to be more likely to have short times. If cannulation by retrograde technique had not been achieved in the first 5 minutes, the chances of eventual success dropped significantly, and crossover to snair was more efficient. The authors suggest that one should consider an alternative method of gait cannulation if it has not been accomplished within this time of 5 minutes. The third paper, Effects of Hospital Safety Net Burden and Hospital Volume on Failure to Rescue After Open Abdominal Aortic Aneurysm Surgery, by Rosero and colleagues from UT Southwestern. They performed a retrospective analysis of prospectively collected nationwide inpatient sample data of failure to rescue, which is defined as the inability to rescue a patient from major perioperative complications, resulting in operative mortality. After adjusting for patient and hospital factors, safety net burden, which is the proportion of uninsured and Medicaid-insured patients, was significantly associated with an increased likelihood of failure to rescue after elective open abdominal aortic operations. Differences in hospital surgical volume, resources, and technology did not explain the higher rates of failure to rescue. The authors concluded that the degree of hospital safety net burden independently increases failure to rescue and mortality after open aortic surgery. The last paper, which is the CME paper of the month, Outcomes for Critical Limb Ischemia are driven by lower extremity revascular volume, not distance to the hospital, by Medicare and colleagues from the University of Rochester, attempted to identify relationships among geographic access to care, vascular procedure volume, limb preservation, and survival in patients diagnosed with critical limb ischemia. They used the New York Inpatient Statewide Database and analyzed 49,576 patients with critical limb ischemia. Patients who presented to hospitals that performed higher volumes of lower extremity revascularization, had lower amputation rates and 30-day mortality, and patients living closer to the treating hospital had worse outcomes. The authors recommend that patients with critical ischemia should be referred to hospitals that perform higher revascularization volumes. Please enjoy reading the entire August issue of the Journal of Vascular Surgery, and thanks very much for your attention.